Dr. Randolph Rao, who joined us, and he's still is wet behind the ears with his retirement, but he sure that he was going to be here, and he's still committed to the school and students. And Dr. Rosario, thank you both for the work you've done to help move Marissa forward.
Recording in progress.
It's my pleasure to actually introduce her, but as everybody knows, Marissa Robinson, she makes sure that you know her when she comes around.
So true.
Yes, she makes sure that people know that she's present. She's been great. She joined us in August of 2019, and she came in the door actually before we had orientation. She had reached out to me saying one of our alum, Donna Ellison, recommended that she talk to me about HIV, and she's been talking HIV since August of 2019. So Marissa currently she works as a management analyst within the HH Office of Infectious Diseases and HIV/AIDS policy in Washington D.C. And she has included her professional work in her academic journey in terms of her interest in HIV/AIDS. So at this point, I'm going to turn things over to Marissa Robinson to share her final dissertation with us.
Thank you so much, Dr. Edwards, and to my committee and to the School of Community Health and Policy for this opportunity. Good afternoon, everybody. My name is Marissa Robinson, and I'm a DRPH candidate. It feels really good to say that. And my study is entitled A Qualitative Exploration of Pre-Exposure Prophylaxis among Black women attending a historically Black college and university in the Northeastern United States. So I'm going to start off with a brief introduction, my literature review, and then move through my methodology and results, followed by my conclusion and discussion, and ending with the Q&A portion. So I'd like to set the scene for what things look like in the Black community. According to the literature, 32 million lives have been lost to human immunodeficiency virus, also known as HIV globally. However, in the United States, recent data from the Centers for Disease Control and Prevention, CDC, indicated that in December of 2019, African Americans accounted for more than 4 out of 10 HIV deaths. Alarmingly, CDC 2020 data reported African Americans are diagnosed with HIV 8 times more than their non-minority counterparts, despite comprising of only 13% of the total US population. I'd like to highlight the CDC graph on your screen that notes that in 2019, CDC reported new HIV cases in African Americans were at 42% of total diagnoses in the United States. And lastly, in 2019, 34,500 persons were newly identified as having HIV. And of those individuals, 9,018 were white, contrasted with 15,340 that were Black. So HIV continues and has been a stigmatizing and taboo subject for many members of the Black community, which significantly impacts Black women. Historical barriers to HIV prevention exist among African Americans, including historical medical mistrust, distrust of the US government, internalized racism, conservative religious sexual values and attitudes, as well as HIV conspiracy theories. The literature identifies a significant absence of conversations surrounding HIV and sex education within historically Black colleges and universities, or HBCUs, which has perpetuated HIV-related stigma and silence. Although HIV is a manageable infectious disease that through proper medication adherence cannot be transmitted to a partner or child, misinformation, gender-specific stigma, and internalized stereotypes often appear in conversations surrounding HIV within the Black community. Due to the large population of young African American women attending HBCUs, these institutions can be essential access points for administering HIV testing, assessing sexual health knowledge, targeting social norms, assessing risky sex practices, and reinforcing targeted HIV prevention, such as pre-exposure prophylaxis, or PrEP. Per Quokka 2018, PrEP is a daily oral medication that can prevent HIV transmission and can benefit numerous sexually active individuals. So this phenomenological qualitative study aimed to explore the perspectives of PrEP uptake among heterosexual, cisgender Black women currently enrolled at an HBCU. This phenomenological approach is suitable because it facilitates the exploration of participants' lived experiences. The study aims were as follows: to characterize the awareness of PrEP among Black HBCU women, to identify factors that may facilitate or cause barriers to Black HBCU women's knowledge and uptake of PrEP, and lastly, to identify best practices for successful marketing strategies for PrEP campaigns targeting uptake among HBCU women. So Black women continue to acquire HIV at excessively high rates compared to white and Hispanic Latina women per CDC data from February 2019. According to CDC data in 2019, Black women in the South acquire HIV at almost 20 times the rate of their white counterparts due to structural racism, socio-contextual factors such as housing, education, socioeconomic status, and poverty. An influential component to Black women's HIV rates is mode of transmission. According to CDC, heterosexual contact accounted for 86% of new HIV cases among Black women in 2017. Based on 2016 CDC data, 1 in 48 Black women will acquire HIV throughout their lifetime if current trends continue. Overwhelmingly, many college students lack adequate awareness of their risk of acquiring HIV and other sexually transmitted infections. According to the CDC, over 10 million new sexually transmitted infections affect individuals aged 15 to 24, which includes college-age African American women. So for Black women in the US, the risk associated with acquiring HIV occurs at a disproportionate rate, regardless of education level or socioeconomic status. Black women are 15 times more likely to develop HIV than their non-Hispanic white counterparts, and countless factors, including low income considerations, low HIV risk understanding, concurrent sexual partners, unsafe sex practices, lead to Black women remaining overrepresented among those impacted by HIV. Despite those countless factors, prevention methods exist to protect Black women. Pre-exposure prophylaxis, or also known as PrEP, is a daily oral medication that can prevent HIV transmission by 99%. The medication was approved by the Federal Drug Administration, FDA, in 2012. However, almost 10 years later, in 2022, only 7,000 of the 500,000 who would benefit significantly from PrEP have been prescribed the medication. And as of 2018, the CDC reported only 7% of cisgender heterosexual women are on PrEP, with less than 1% of those women identifying as Black. I just want that number to sit with you. And according to the literature, Black women have lower PrEP awareness, lower PrEP coverage, and if they know about PrEP, do not know where or how to get it. This phenomenological qualitative study had 3 research questions. The first one was, what is the awareness of PrEP among Black HBCU college women? What factors influence PrEP uptake among HBCU college women? And what are the barriers and facilitators regarding PrEP uptake among Black HBCU college women? So this is a qualitative study that examined why some of the barriers and facilitators of PrEP uptake impact college-age Black women, which was expanded upon the parent study of Chandler Hall et al. 2020. Collaboration with the parent study author and PI, Dr. Rashida Chandler at Emory University School of Nursing, was essential to ensure overall study preparedness and implementation for the secondary study. The Chandler Hall et al. 2020 parent study was a mixed method study, which was conducted amongst a Black HBCU, was conducted amongst Black college women at an HBCU in Florida. The study piloted a PrEP education intervention to determine Black women's perceptions of and receptivity to PrEP use and preferences for PrEP information delivery. The study found that most Black college women had not heard of PrEP, and after the health education module, would strongly consider PrEP initiation in the future. The study complemented the parent study by furthering understanding of contextual factors beyond the individual. This included negative attitudes towards PrEP uptake, historical traumas of public health research, HIV risk beliefs, and perceptions. The secondary study utilized a qualitative-only approach at an HBCU in the Northeast, which facilitated the collection of in-depth information about the participants' beliefs and attitudes about PrEP. Additionally, the study mirrored certain aspects of the parent study, which was the health belief model conceptual framework and the focus group guide, which were both further developed for the current study. So this study addressed the predictors of PrEP uptake within the context of the health belief model. The health belief model, or HBM, is a socio-cognitive theoretical framework used to describe and predict people's behaviors. According to Flesher et al., the health belief model addresses why people fail to engage in preventative measures despite the availability of screening, contraceptives, and health risks. This model's adaptability allows it to be applied in different contexts, such as with HIV and PrEP uptake among African American women. This model was adapted from the parent study Chandler Hall et al. Of the health belief model, which used 5 constructs to determine behavioral factors. Those are individual perception of threat, modifying factors, likelihood of action, self-efficacies, and cues to action. Briefly, I'd like to walk through the health belief model as it relates to Black HBCU women's uptake of PrEP. First, we have the individual perception of PrEP. Individual perceptions of threat. In this case, this includes the risk of HIV infection and associated health problems. The modifying factors affecting PrEP uptake may include demographic variables such as age, education level, ethnicity, gender, personality, and socioeconomic status. The likelihood of action includes the perceived benefits of taking PrEP, which is the recommended health action on the prevention of HIV among HBCUs. The cues to action includes a CDC recommendation as well as HBCU PrEP campaigns. The perceived benefits involves the advantages of PrEP for Black female HBCU students. The perceived barriers include inadequate awareness, doubts about PrEP efficacy, and concerns about side effects. So I'd like to move into my study design and data collection. So this was a qualitative phenomenological study design. All recruitment strategies occurred virtually, which included word-of-mouth recruitment and electronic flyer distribution among Morgan students. The recruitment flyer that was utilized is on your screen. The flyer as well included information about the study and a URL link to a Google Form survey. I successfully recruited students through the School of Community Health and Policy, the Office of Residence Life, the Office of Health Promotion, the Office of Student Life and Development, and the Graduate Student Association, as well as Morgan's listserv via email. The inclusion criteria for my participants included current Morgan students, Black and African American, were assigned female at birth, were 18 years or older, were sexually active, and HIV negative. Additional information that was collected included relationship status, multiple sexual partners, or inconsistent condom usage. Once the students completed the baseline inclusion survey, participants were formally enrolled into the study with the completion of an informed consent form. A semi-structured focus group guide was adapted from Chandler Hall et al. And was utilized once the focus groups were successfully concluded. Participants received an incentive of a $25 electronic Amazon gift card for their participation. The participant incentives were sponsored by Morgan State University's Center for Urban Health Equity, and I want to give a special thanks to Dean Sidnor for the support. Utilizing purposive sampling, 200 students were interested in my study, 138 completed the baseline inclusion survey, 40 participants were recruited, and 22 participants successfully enrolled and completed my study. I successfully conducted 5 virtual 60-minute audio-only virtual focus groups from January to March of 2022 that were transcribed verbatim. Based on the focus group transcriptions, a thematic analysis utilizing Braun and Clark's framework identified codes, patterns, definitions, classifications, and themes with MaxQDA data analysis software. Overall, 4 major themes emerged from the focus groups. The first one was knowledge and awareness of PrEP. The second was perceptions of PrEP. The third was the facilitators of PrEP uptake. And the fourth was barriers and facilitators for PrEP uptake. Excuse me. I went too far ahead. Okay. So let's chat further about my study participants. So 100% of the participants were assigned female at birth, self-reported as current Morgan students, and were HIV negative. 19 participants were aged 18 to 25, 14 were single, 7 were in a relationship, 86.4% of participants did not have multiple sexual partners, and lastly, only 50% of the participants reported inconsistent condom usage. So I'd like to take a deeper dive into the study results by theme. So my first research question, what is the awareness of PrEP among Black HBCU college women, was answered with the first main findings, which was the first theme of knowledge and awareness of PrEP. The first theme reported the following results: that there was a gap in PrEP knowledge, parents avoiding sex conversations, there was a greater understanding needed for sexual and reproductive health, and that providers were not promoting PrEP, sexually transmitted diseases, or their long-term impacts. One of the participants said the following: "Oh, right now in this study, this is my first time hearing about PrEP." Now, this study was conducted in 2022, and as I stated, PrEP has been around for 10 years. So next, my second research question was what factors influence PrEP uptake among Black HBCU college women, was answered with the main findings with the second theme, which was perceptions of PrEP. This theme yielded the following results: that it could lessen your chance of getting HIV, and it could also reduce the viral load of HIV. I did want to note that PrEP cannot reduce the viral load of HIV, thus the PI of the study informed participants of this finding after the participants had answered the question to help educate the participants properly. One of the participants shared that PrEP does prevent HIV from happening, but that's all they really knew. The third research question had 2 parts. I've broken them down between facilitators and barriers, so let's start with the facilitators. The third research question was what are the barriers and facilitators of PrEP uptake among Black HBCU college women? The third noted theme was facilitators of PrEP uptake. The reported theme yielded the following results: that there was exposure to HIV, unprotected sex, and effectiveness. One of the participants said, "I agree with the last participant. If I was exposed to it," meaning HIV, "that would definitely motivate me to consider trying PrEP." Lastly, the fourth and final theme focused on the barriers of PrEP uptake. The main finding within the fourth theme was fear of side effects, stigma, and cost. One of the participants said, "I agree with what she said because I feel like in my community, there's kind of like this stigma that HIV is like a gay problem." I did also want to highlight that various unintended or serendipitous themes were found in this study, including the need for more education in various topics, including birth control, STI and STD testing, and breast cancer. Participants also highlighted the importance of testing for HIV before having sexual relations, and participants indicated that PrEP should be more frequently and openly discussed at HBCUs. So what is the study's significance? Well, this study is of significant importance because PrEP uptake is a topic of concern in the African American community. Findings from this study can provide information that can encourage policymakers and stakeholders in HBCUs to improve uptake of PrEP among Black women. Based on the results, there is a gap in knowledge and awareness of PrEP among Black women attending HBCUs. Therefore, the findings can be applied in developing programs and policies to increase PrEP uptake among Black women in colleges and universities. This study came with some limitations, which have been narrowed to the following: the generalizability of findings, COVID-19 pandemic restrictions, online fatigue, social desirability, recall, investigator, as well as selection bias. This study is only reflective of the Black women who attended Morgan State and not other Black women at other HBCUs in the same or other states, or Black women at predominantly white institutions. The global pandemic caused many restrictions, including limited in-person recruitment or focus group implementation. So all recruitment, communication, and focus groups had to be held virtually. Online fatigue could have resulted and caused exhaustion to participate in this study. Social desirability could have been experienced due to the very sensitive nature of the questions, making it likely participants potentially provided desirable responses. But despite these limitations, there was a lot of success. This study was done, and this study participants provided firsthand recommendations for future PrEP campaigns, which can inform innovative and new insights for HIV prevention among HBCUs and beyond. Although CDC PrEP guidance has been updated and national PrEP campaigns exist, PrEP campaigns and tailored medical guidance for Black women at HBCUs should be created to address the disparity among Black women and HIV. Policymakers can also apply the findings to develop policies to increase PrEP uptake and awareness in HBCUs. In addition, policymakers can begin identifying ways to develop effective legislation to increase access to PrEP by African American women. In addition, student health leaders and program educators can help apply these findings from the study to expand existing PrEP and educational programs to increase Black women's access to PrEP medications, routine testing, and other related disease prevention. Increased national PrEP campaigns, PrEP training, and awareness amongst healthcare providers, as well as tailored medical guidance for Black women at HBCUs needs to be created to address the disparity. Future public health efforts must utilize an individualized, culturally appropriate framework for PrEP delivery and uptake for Black women. College-age women want to see reflections of themselves, not only in an HBCU PrEP campaign ad, but PrEP used among their trusted peers and peer leaders, such as within sororities, student government associations, social media sites like Instagram, TikTok, and Twitter with easy to understand and accessible bite-sized pieces of information. This can include things like cost, side effects, where to get it, etc. And although the PrEP guidance has been updated, utilizing community guidance that reframes HIV prevention and convenes Black women like that of ViiV Healthcare's Risk to Reason is an innovative new framework to connect Black women on HIV prevention and analyze current strategies for better common practice. Reshaping current cultural beliefs begins with honest conversations, acknowledgement of stigma, historical traumas, and the various structural and social determinants of both the community and the individual. Various recommendations can be drawn from the findings of this study, and amongst the most common themes was the gap in PrEP knowledge. Therefore, HBCUs need to further explore the unique perspectives, attitudes, and knowledge surrounding PrEP uptake among students, particularly Black women. Pairing the student perspectives with increased on-campus PrEP information and on-campus PrEP provider, and normalizing sexual health conversations can further this study's impact on the HBCU community. We need to include conversations around reproductive health and contraceptions, as this may be an additional concern for women interested in PrEP. Black women are an integral part of society, and future PrEP uptake by Black women at HBCUs is imperative for national HIV prevention efforts and achieving the Ending the HIV Epidemic goal of reduction by 90% by 2030. Lastly, I want to dedicate this to all the Black and brown lives this research may impact. From fellow researchers to those whose lives have been impacted by HIV, I am here as an ally, an advocate, and a positive voice of change. I pledge my career to serve our community, and in the famous words of Issa Rae, I am rooting for everybody Black. I want to take this time before I conclude to acknowledge my chair, Dr. Louise Edwards, Dr. Randolph Rao, Dr. Michelle Sandoval Rosario, and my Emory University School of Nursing mentor, Dr. Rashida Chandler, for all of you believing in me, encouraging me, and helping me get to this point. I am forever grateful for your guidance and mentorship that you all have provided me. And I'd like to open this time for question. Thank you so much.
Okay, thank you, Marissa, for your presentation. And now we are going to open questions to our leadership and faculty.
From your committee first?
Oh, from the committee first? Okay. Dr. Rosario and Dr. Rao, are there questions?
Sure, well, I'll go ahead and jump in. I see there's questions from coming in from participants, but Marissa, first of all, great presentation, very important topic. One thing you said, PrEP has been in the market for over 10 years, and there are still individuals, specifically Black women, who are unaware, so that's a very disturbing knowledge to take in. But one thing that I did want to ask, did you discuss anything with PEP? Because when you were talking about some of the quotes, it looks like some of the participants got confused that PrEP was to prevent exposure. So I'm curious if there was any conversations on PEP also in addition to PrEP.
Absolutely. So in the focus groups, when participants did say that PrEP would be able to protect them against HIV exposure, and if they were exposed to HIV, that they would need to then use PrEP, I then educated them not only on PrEP but also of post-exposure prophylaxis. So that was one of the things that I noted as the PI of the study, to make sure to educate my participants about both PrEP and PEP, being if there was a post-exposure, or also making sure that you were being proactive in utilizing PrEP.
That's great. And then my other follow-up question, one of the common things in reading your dissertation and hearing you was really this theme around perceived risk, right? We know, particularly, there are still cisgender women who think HIV only impacts the gay MSM community, which we know is incorrect. So I wanted to further ask a question around perceived risk. Did you see any differences between those who were in relationship versus those who had multiple partners? Because I thought, looking at the numbers, it said that only 50% had consistent condom usage. Did you dig in a little deeper, kind of what the perceived risk was for those?
Right. So definitely the perceived risk was different amongst several of the participants. I did note that with some of the participants, all of the participants, all of this information is self-reported. And because there were focus groups, hearing other conversations, there could have been a reporter bias in terms of what they were responding to, based on the other conversations that some of the other participants had shared. Some of the participants range from freshmen to doctoral students. I did have one participant who was married, so her perception of her risk was that she wasn't at risk because she was in a monogamous relationship. Some of the other participants shared that they were also in monogamous relationships, but PrEP gives them the opportunity to have a woman-centered and controlled biomedical intervention. And so that was the main educational point for all of the participants, was that no matter what your relationship status is, no matter if you have inconsistent condom usage or consistent condom usage, you can protect yourself with arming yourself with PrEP.
Great, thank you. I'm going to give an opportunity for the other committee members to ask some questions, but well done. Excellent. Thank you.
Oh, Dr. Rao, you're on mute.
Okay, sorry. I would concur with that. Very well done presentation. I want to go a little bit into the barriers. In terms of the barriers discussed, which ones seem to be most concerned to your audience?
Absolutely. So side effects was the main concern, as well as the stigma. So a lot of the participants shared that within their relationship, if their partner knew that they were taking PrEP, there would be some sort of stigma of, oh, why are you taking PrEP? Do you think I have something, or do you think I'm cheating on you? Which would then perpetuate this stigma and negative attitudes towards this medication, even though they would be able to protect themselves and use the medication freely. The other thing was talking about side effects and what those impacts would have on our bodies. being that we are still in the COVID-19 pandemic, I think a lot of medical mistrust is out there and false information. And when folks are talking about vaccinations as well as putting things into their bodies, they're taking a real closer look at what are the impacts to my body, what is the impact on pregnancy, what is the impact with my birth control. So these are all things that were brought up by the participants as things that would be of concern. So those side effects and how they would interfere with any current medications, if they have any underlying conditions, those are some of the things that some of the participants said. But the main theme was side effects overall, and then cost as well as stigma were the top three.
Okay. So, Evan said that as a public health practitioner, where would you give me an example of how you would address these particular barriers to get this particular audience up to speed and in a better place than they are today?
Absolutely. So to address some of these barriers, I would make some recommendations to first start with education. So without the education, we don't have the knowledge. So if we don't know anything about and aren't aware of anything associated with PrEP, we can't start to then help with the health literacy there. So I would first start with the education piece. So sharing information about PrEP, talking to their providers, talking to pharmacists, talking to trusted community members, whether that's a community health worker, a PrEP navigator, or your OBGYN, or an emergency doctor, a medical doctor, someone in the public health field. It doesn't always have to be medical. And then I would say that when we're talking about cost, we really need to look at that from a policy perspective. So that is something that I would talk to my colleagues at Health and Human Services to see what things can we do to impact and help the cost of PrEP, because it is very expensive. Talking about some of those side effects, that is a pharmaceutical side effect. So because it is a pharmaceutical drug that we would be talking about, I would want them to have conversations with persons of lived experience. So current Black women that identify as cisgender and are heterosexual, I would want them to have conversations with persons of lived experience to see what their impacts have been personally as well as physically and emotionally, and what they would recommend for those students. So those are some of the things that I would do to kind of take it a step further to address some of those barriers.
You didn't mention parents, and a lot of these college students come in, some of them were younger.
Yes.
But you didn't, as a secondary audience, you didn't speak. What would the literature say? I should have asked.
Absolutely.
Parents' role and perhaps did any of the conversations speak to possible role of the parent?
Yes, so when we talk about the knowledge and awareness of PrEP, a lot of the parents did not even talk about protecting these women from a sexual transmitted disease or infection perspective. The only concern that most of the parents had discussed was the fear of pregnancy. So that's what a lot of the parents who were having conversations around sexual and reproductive health were only concerned about these women being pregnant, and not about the sexually transmitted diseases or infections or that risk. So that is another area, including provider bias of not thinking that the individual who comes into the clinic or comes into the office is at risk. Those are some of the things that also could help perpetuate and break down the barriers that we've identified in this study.
Okay, thank you. My last question would be your rationale for framing this as a phenomenological study. Could you give us some insight on that?
Of course. Because this study is a secondary study, I did not want to go too far away from the original parent study framework. And I knew that persons of lived experiences, especially when we're talking about a very sensitive topic, when we're talking about sex, we're talking about things, risky behaviors, these are all things that are better discussed with trusted and rapport building communities. And so talking about lived experiences can help break down some of those barriers in terms of how to communicate effectively and openly and being honest. And like I said in some of my future recommendations, if we're going to change the next 40 years of this epidemic, talking about HIV, we have to do things differently, and having open conversations, breaking down the medical mistrust, and breaking down and having those honest conversations is all the start of something new.
Thank you very much.
Thank you.
Okay, Marissa, I have a couple of questions for you as well. You just mentioned 40 years, and HIV has been around and for the last 41 years.
Mm-hmm.
Um, you also mentioned that PrEP is in its 10th year.
Mm-hmm.
What do you think is some of the possible reasons why Black women are not knowledgeable or do not have an awareness of PrEP and preventing or minimizing the HIV acquisition?
Absolutely. So when PrEP first started, it had a lot of strong uptake within same gender loving male communities. And that is where a lot of the campaigns were. That's where a lot of the dollars have gone. And so that is a lot of what we're seeing in the media with the ads. Some of the participants also alluded to the Descovy commercial that only talks about the PrEP medication that is only for those assigned male at birth or those that identify as trans women. And so that does not include women, and especially does not include Black women. So a lot of the participants noted that.
Do you have any suggestions on what we can do to modify the gender issues regarding PrEP uptake?
Absolutely. So to address the gender issue with PrEP uptake, like I said, it starts with conversations. I was just in Atlanta 2 weeks ago for the first ever PrEP in Black America Summit. It was led by a lot of community-based organization and leaders that are within the Black community. Because if we break down all of these labels and just focus on us as a community, we can do so much better. And so not just looking at women, not just looking at same gender loving men, or not just looking at men, but looking across the spectrum, looking at our persons of lived experience who already have acquired HIV and may be or may not be virally suppressed, and hearing about their stories, talking to men, women, persons of trans experience to hear their perspectives and what they have learned from either being a PrEP user or being HIV positive. Having this status neutral approach is what's going to get us to the next step. And that will help to break down some of the barriers we are seeing with uptake in terms of gender. In terms of race, when we're talking about race and ethnicity, us as a whole, as a Black community, we can do so much better together than apart. So I think helping reach across and be collaborative and be inclusive, and again, like I said with Dr. Rao, talking about having those honest conversations, breaking down the medical mistrust is going to take years of hard work, but I think we can do it, and I'm definitely up for the task.
And Dr. Rao did mention the role of parents holding conversations around PrEP. Do you think possibly that parents do that simply because they are not aware of PrEP as well?
Absolutely. There's an overall, in the Chandler Hall et al. Study, there was an overall gap in PrEP knowledge and awareness from the participants and from lived experiences. So if we're seeing this in educated Black communities for those that are college-age women, I think that can also be said for looking at future studies to see what is going on in the greater community when we're talking about Black women as a whole and talking about the African American community and the lack of having sexual conversations around reproductive health.
Okay, and I did want to ask you, I recently read an article that talked about HBCUs missed the mark when it came to informing students about PrEP. What would be some of your recommendations, and how do you feel about that?
Absolutely. So missing the mark, talking to students, I think is something that we can change, right? This is something that we can control. And this is something that with effort, with collaboration with student-led organizations like sororities, fraternities, student government associations, the Mr. and Mrs. of the universities, talking to student health providers, ambassadors, and really focusing on a collaborative effort is gonna, I think, can change this. I'm so optimistic about what I've seen in the research because students and participants did share that they're interested in learning more. It sparked an interest. And so I believe that with continued future development of this study, and taking it to a larger audience and looking at other historically Black colleges and universities, we really can begin to have these uncomfortable conversations. And starting with honesty, breaking down the myths, and breaking down all of these barriers, it's going to take time. But I think, like I said, we can do it, and it's all possible. But it all starts with, acknowledging all the things that we've done in the past and trying to change that for the future.
In the same article, they mentioned that whites were 6 times more knowledgeable about PrEP than blacks or African Americans. What would be one of the main strategies that you would implement to increase that awareness and knowledge?
Among Black students?
Yes, and in general, blacks in general. Your research happens to be on the campus, but for our population in general is my question.
For our population in general, is going to take taking all of the things that were learned at the PrEP in Black America Summit, taking community-based organizations and their perspectives, taking federal and policymakers' perspectives, state, local, and federal government associations, health associations, to come together and collaborate. Public health is all about interdisciplinary fields and talking and sharing ideas and information, figuring out what are the best practices, what are the lessons learned. The Centers for AIDS Research, the CFARs out of the National Institutes of Health, lead Centers for AIDS Research and talk about all these different interventions that are possible and that are ongoing in the community. There was just a meeting in Birmingham, Alabama last week where several researchers from NIH talked about certain community members that are doing collaborative work with the NIH and are funded through the NIH to do community-based research. And I think that having some of these best practices and some of those lessons learned are going to be imperative for us to not make the same mistakes and to move forward in a positive direction.
And my last question is, I read an article that said 700,000 young people of color would benefit from PrEP. And HBCUs or academic institutions are good places to start. Where do you think Morgan State University could begin such work? In terms of what unit, school, where, and what would be the good spot to begin to increase awareness of PrEP among college students?
I think the School of Community Health and Policy is a great place to start. Being that I housed my dissertation here and my research started here, I would be interested in what opportunities there are to pursue this work for a career perspective. And I think starting with conversations with dissertations, it starts with the data. It starts with the persons of lived experience, and it starts with what is going on with the research. And that's what can move and to start these discussions. So I think this is a great starting point to maybe kick that off. And I'd be interested to see what opportunities are available in the future.
Thank you. I pass on to leadership.
Dr. Hopkins, you want to go first or me? Or? I mean, either way, I can start. You'd like to close out? Okay, great. Thank you so much, Marissa. Some of the questions I wanted to ask you, you've been able to answer during your responses to others as well as during your presentation. So I do have like two that are kind of related to it. It just gives you an opportunity maybe to elaborate on something you've spoken about already. Mm-hmm. And one of my areas of interest, I was thinking about how attitudes around vaccines actually affect attitudes around prophylaxis. Mm-hmm. So particularly you're talking about pharmacological prophylaxis. Right. And you mentioned the various concerns that the women express. Mm-hmm. Would you care to elaborate a little bit more on how you see things like general, not just COVID, general vaccine hesitancy or concerns around vaccines and
Absolutely. Thank you for the question. So, first and foremost, medical mistrust, distrust of the government, distrust of the medical system, distrust of providers, distrust of anything scientific is historical. So I want to start there. From a historical perspective, Black and brown lives have been operated on, have been mutilated, have been abused, and so a lot of the mistrust has been over 400 plus years, stemming pre-slavery. So it goes back very strongly for the mistrust of other persons. Second, when we're talking about from a prevention aspect, a lot of our healthcare system is very treatment based. So it's after the fact. It's after you are sick. It's after you've gotten COVID. It's after you've acquired a infectious disease such as HIV. So changing our mindset is going to take not only time, but building that rapport with folks to have the trusted medical provider is also a part of that equation. So reversing some of these systems that we've built in the healthcare system in terms of focusing on treatment, and we can start at prevention. The Ending the HIV Epidemic initiative has 4 pillars: diagnose, treat, prevent, and respond. We need prevention. Prevention can save lives, can save money, and if we focus only on treatment, we're missing so many missed opportunities. So focusing on prevention instead of treatment, or as prevention, treatment as prevention, are some of the things that CDC has noted in some of the guidelines.
Okay, thank you. I'll give you one, there's some feedback, and then I have my second question.
Absolutely.
Just in general, understanding that we've got some information. It's more complex when we think about mistrust, and
Absolutely.
because quite frankly, the data shows that African Americans had a very high representation in terms of participating in the clinical trials for the COVID vaccines.
Mm-hmm.
So in an area where we probably would have expected different, it was very interesting to know there was a really more than representative population in the clinical trials for the Moderna and Pfizer vaccine. So it was there. So understanding, you're right, that mistrust is a more complex, because given information, people still may mistrust the system, but may trust other things and look in their best interest. So something to explore.
Absolutely.
My next question, that's just feedback for you to, as you move forward in terms of exploring mistrust. My next question is around a decision for you in terms of your focus of your research. So you raised a lot about the lived experience and exploring the lived experience, and even providing the kind of information that exploring the lived experience of those who utilize PrEP,
Mm-hmm.
Women who utilize PrEP or are using PrEP, understanding that as helping us to understand some of the barriers of facilitators. So my question to you is, did you think about that as a study in and of itself originally? Because if you're doing the lived experience, really to do the lived experience of persons who are utilizing PrEP to really understand what are the barriers of facilitators to PrEP?
Absolutely. So not only did my research from the phenomenological aspect, I wanted to capture the unique perspectives at an additional site, seeing as the parent study was conducted in Florida. There are vast differences from just the state alone of Florida to Maryland, but also just the qualitative piece can build those in-depth descriptions, can share some of those insights that you can't always capture from a survey or from a quantitative only study. So I really wanted to dig deeper into those negative attitudes and where is it coming from, what conversations aren't being had, what conversations could be had, and really dive deeper into that. So that is why I focused specifically on persons that were not were not on PrEP, because I wanted to help bring awareness and knowledge and increase that gap. Because in the Chandler Hall et al. Study, it was noted that there was a gap in knowledge and awareness of PrEP. So we have to first start with the education for those individuals who are at most risk, even though they don't perceive themselves as being at risk. So I wanted to capture that audience, but for future research and future direction, persons of lived experiences are essential to making the changes that we want to see. So I'm definitely open to that opportunity. In terms of when I was developing my study, I was not thinking in terms of lived experience from the PrEP side, because that was going to be a follow-up or an adaptation of my study. So that's something that I'm willing to explore in the future.
Thank you. Dr. Sidnor?
Thank you. Thank you, Marissa. As everybody said, you make yourself known. You are quite knowledgeable in your space, and I really applaud you as a practitioner and now as a practitioner scholar in this space. I did have a number of my questions were answered. I think you sort of answered this, but I'm going to bring it back.
Sure.
Just to clarify. Had you not been building on a prior study, what other questions or approach might you have used? So if you were just freed from all structure around the prior study, would the approach, I guess that should be the question, would the approach have been any different? And then if yes, what would have been different?
Absolutely. Thank you for the question. So because this was a dissertation, I did have a lot of, I would say, optimism when I first started. I thought about, I could do multiple sites. I could look at multiple HBCUs in the same state. I could look at multiple HBCUs in another state and do a cohort study. And then I was looking at, okay, what's already in the literature and what can I build on and what would provide more literature around Black women and PrEP. And that's really what guided me to reach out to Dr. Chandler at Emory first, because she is a scholar in her own right, but also the work that is being done around the collaborative of nursing, medicine, public health. It's also interdisciplinary. So really when my inspiration kind of started for this work, I knew that there were so many ways I could go about it, and I still would use a phenomenological approach. I think lived experiences is so imperative for us to learn from the participants, as well as really to impact change, but also looking at the qualitative piece. I'm a qualitative researcher. I think qualitative research is just as important as quantitative research. And I think moving forward, I dub myself as one of the qualitative experts in the field. So I think that I would continue to do qualitative research even if I were to start from a primary qualitative data perspective and not go from a parent study.
Okay. So thank you for that. I'm going to follow up a little bit again on phenomenology. And so the question in my head is what phenomenon were you really studying by this work? So when you approach these women sort of with a frame in mind, what phenomenon did you really have in mind? And I guess it goes back to my earlier question. Is there any other way you could have understood this phenomenon had you not been building on this prior work?
So I think in terms of this work and in terms of that question, it's outside of the scope of what my original research was focusing on, since it was a secondary study. But the phenomenon of looking at the health belief model and looking at the negative attitudes that are associated with the knowledge and awareness of PrEP, and the gap that highly educated women had already noted in the Chandler Hall et al. Study is really what led me to this point. And so the literature, there is not substantial literature that focus on college age Black women, specifically as it relates to PrEP. So I wanted my study to definitely highlight and contribute to that literature. And so the phenomenon of looking at the health belief model is really what drove this vehicle to get me to this point.
Okay, thank you. And my next question, because I know you have some in the chat, so I'll only ask two.
Okay.
I'm always fascinated by group dynamics, and so these were focus group sessions done over time with different cluster of women.
Mhm.
Was there anything about the focus groups as an entity, as a unit in and of themselves? So I know that wasn't your analysis, but was there anything about the focus groups that was different energy, different tonality?
Mhm.
Anything you can share about that experience just in having different focus groups?
Absolutely. So I had 5 overall, and going from the first to the last one, we were just getting off of winter break during the first round of focus groups. So there was a lot of energy in the first one, and we were going into spring break on the last one. So the first and the 5th one definitely had the most energy because they were either coming off of a break or going into a break. So they were definitely really excited to get the Amazon gift card incentive to be able to purchase something for either the beginning of the semester or to go on spring break. But there was definitely great vibes and insights and conversations throughout all of the focus groups, and I did allow the participants to do member checking, and they did all have open communication with me. So if they wanted to ask questions, if they wanted to reach out to me or connect with me on LinkedIn, if they wanted to learn more about the Masters of Public Health field or learn about the DRPH field or were any sort of inspiration of working in this field, I was very open and candid with them. And so I think some of the participants definitely felt the rapport and felt comfortable during the discussions, but definitely the first and the 5th one, because we were coming off a break and going into one, were very high energy.
So following up on that, and that makes sense to me. In your exemplars that you have in your document, did they tend to come more from the 1st and 5th, or really you found like a good exemplars across all the focus groups?
Yes, I found examples all throughout all 5 focus groups, and how I knew I had achieved saturation was because by the 4th and 5th focus groups, I was hearing some of those same themes: that cost, that fear of stigma, the fear of side effects, the lack of provider knowledge, the lack of parenting conversations around sex outside of pregnancy. So a lot of the themes were really truly met the saturation by that 5th focus group, but definitely throughout all 5 there was a breadth of knowledge, and I'm open to sharing. I have everything in a password protected database, including the audio files and the transcription. So yep.
Yeah, I bet there's a lot there.
Yes.
That didn't necessarily wind up here that would be of great interest to people. So
Absolutely.
Thank you for that.
Thank you.
Okay, I want to give Department Chair Baptiste Roberts and Dr. Barrett opportunities for questions, if you will.
Sure. Thank you so much for the opportunity to ask a question. I just had one question. You mentioned in your presentation about legislation. I was wondering what kind of legislation were you thinking about that would be helpful to increase PrEP uptake in this population?
Absolutely. So the Centers for Disease Control and Prevention in December of 2021 actually updated their PrEP guidance. And PrEP guidance is one of those frameworks that helps providers and participants that are interested in PrEP to be able to receive the medication. So one of the pieces of legislation that I have definitely alluded to in my dissertation and would like to see further developed is that PrEP guidance. One of the biggest changes was that if someone comes into your office or your clinic or the emergency room and they say they want PrEP, no questions asked, it's supposed to be prescribed. So that is one of the changes that has come out of community-based participatory research, and I think we must continue to do CBPR in order to change and move the policy. So in terms of legislation, the PrEP guidance that is currently in, that was published in December of 2021, that is the guidelines that I would focus on for legislation.
So this issue, so guidance is one thing and legislation is something else. So I guess I was trying to figure out how you were thinking of using legislation to, I guess, enforce the guidance, or
Okay.
because guidance
Yes.
is separate from a
Absolutely.
mandate, or
Absolutely. So Ending the HIV Epidemic initiative is one of those HHS-led initiatives. And that is something that I do in the Office of Infectious Disease and HIV/AIDS policy. So some of the policy that implemented the Ending the HIV Epidemic initiative started in the previous administration, but we now have the National HIV/AIDS Strategy Federal Implementation Plan that just got released a few weeks ago. So we're working closely with the Office of National AIDS Policy to enforce the federal implementation plan. So part of the National HIV/AIDS Strategy uses Ending the HIV Epidemic as a tool and a vehicle to help get us to the reduction of 75% by 2025 and the reduction of 90% by 2030. So those are the things that I would be focused on in terms of legislation.
I'll defer to Dr. Barrett.
Dr. Baptiste Roberts, you were in my lane, so to speak, because I was going to ask you. You mentioned policymakers, and so with Dr. Baptiste Roberts' question, it began to answer that question. I was interested in how you were going to target, policy specifically for African American women. I would turn my camera on, but I don't have that capability. It says the host won't let me turn it on. So anyway, that's why you have my picture.
Okay.
Okay, your face can now be shown, Dr. Barrett.
Okay, good. Maybe not.
Oh, there you are.
And so I was really curious, how policy specifically for African American women, and why would that be different for some other population groups?
So in looking at the National HIV/AIDS Strategy, one of the key populations is African American women. And so I think I acknowledge that there is a gap from not only a community level, a state level, but a national level. So now talking about the federal implementation of what are the local jurisdictions going to do and what are the states going to do to close this gap and address this gap is something that is currently happening. It's so interesting to hear all of these questions because you can't hear me?
We have an audio issue going on here.
Yeah, your audio just went out, Marissa.
Can you hear me?
Yes, we hear you.
Okay. Can you hear me?
Yeah.
Okay. Did you hear anything I said? I'll just start.
Yeah,
Oh, you did?
Yeah, I did.
Okay.
Just that last little bit.
Oh, the last bit. Okay. So it's so interesting to hear all of your questions because where I sit in the Office of Infectious Disease and HIV/AIDS Policy, we see so much from the community level all the way up to the federal level. So we really get a breadth of knowledge in terms of what we're hearing and seeing from the community. And so from this perspective of what we can do as policymakers, I also wear so many hats in my profession, and being a policymaker and implementer, as well as an innovator and a mover and shaker, if you will, is something that I pride myself on. Dr. Sandoval Rosario is one of our Prevention through Active Community Engagement Commission Corps officers, and I worked very closely with her during my internship, as well as I work with her as a collaborator in the field. And we work very closely to talk about what is going on the ground and what we can do at the federal level to make those changes that the community is stating. We just had the presidential HIV/AIDS council meeting that was in LA. So it was last week, and we heard from community members about what they wanted. We updated them from the federal implementation plan. We also conducted site visits to go to local jurisdictions to hear what the community is doing and seeing some of those, speaking with some of those persons of lived experience. So it really is all encompassing when I look at the many hats I wear. And so some of the findings from my research is definitely going to my office, but it's also because of collaborators like her and some of my colleagues that we really can make a change.
Yeah. I remember when you were doing your field placement.
Yes.
Yeah, and it was the long distance issue.
Mm-hmm.
And so I'm glad that worked out.
Yes, ma'am.
I also had a question in terms of the focus group, and Dr. Sidnor touched on that. I noticed you were dealing with 18-year-olds and 25-year-olds.
Mm-hmm.
And so, did you have them in the same group, or did you have them in separate groups? And were their questions and responses significantly different, since the group basically didn't have awareness about PrEP?
Right. So for those individuals who had friends that identified within the LGBTQIA+ community, some of them did have previous PrEP knowledge. But for the majority of the group, unless they had friends or they had known previously about PrEP prior to coming into the study, there was a lack of awareness of PrEP overall. And even with some of the doctoral students, they had maybe seen PrEP on the commercial of Descovy, but they didn't know that it was for Black women. So again, even highly educated, this entire population was highly educated, being that they are in higher education. But to see that there is still a disparity, even at the doctoral level, even at the freshman level, I mean, it truly is, unfortunate, but it is something that we can change, right? And it starts with conversations. It starts with research like this. So I'm really proud that I was able to at least share the information that is out there.
And so as a result now, are they more interested in
Yes.
learning everything again about
Yes.
that?
Yes.
So what about our international students? I'm sure they heard about the study or saw the flyers.
Mm-hmm.
And so how would you deal with the international students that we have? We have a very high population of international students,
Mm-hmm.
from Nigeria, etc.
Mm-hmm.
And so I would think that there would be interest on their part also. And how hard would it be to be able to bring them in as part of the educational process?
Well, because this, my key or focus was the inclusion criteria was that they identified as Black or African American, that definitely would limit the international students. But for those that were that still identified as African American but might have been Caribbean or might have been from Nigeria, they did put that in their inclusion criteria. So that would be an area that we could further explore moving forward. I could just alter my inclusion criteria.
Yeah. Well, I was thinking, I wasn't talking about your current study, but I was thinking the applicability,
Mm-hmm.
to the international students who attended HBCUs.
Understood. Yes.
Yeah.
That is definitely an area to explore for future studies.
Yeah. Well, you did a wonderful job in presenting your research.
Thank you so much.
I'm very proud of you.
Thank you.
Great job. Okay. That's it for me.
So, I want to thank everybody for their questions, and I know we have some questions from the audience, but due to time, we will be sure to share your questions with Marissa and the committee, and we thank the audience for being here and for asking questions. And it's just not enough time to get to everything, but we will be sure to share your questions. And we thank
you.
So we ask that everyone please
Mhm.
exit the room,
Yes.
right now. We could do that right now, that would be great. You know, we have a slew of people here, so the faster that you could end your session, the faster we could get to deliberation.
Thank you, Ms.
So we're being kicked out,
No,
okay.
I think basically.
No, not you, not the panelists.
No, you
Yes,
could,
the attendees.
you should close out the webinar.
Recording stopped.
I should what? You should be able to close out the webinar. I didn't get to that class yet. I see nowhere where I have to do it one by one.
So, Dr. Hopkins, we should remain
Where do I go, Dr. Hopkins? Yeah. It says, yeah.
participants.
It's attendees versus participants. All the attendees need to. Yeah, I'm gonna have to just remove them one by one.
Wow.
Yeah, I don't see where, that would be a good feature though.
Mhm.
I believe there is a way to do that, because in other places you do see,
Yeah.
view options. Let me check. Oh, I've got no more options to view. What do you call it?
That's my expertise.
You're getting there. We went from 99 to 19.
No, I don't see any.
99?
Yeah.
Right, there were that many people participating,
Wow.
listening.
Things at 99.
Now we only have 8 attendees.
Yeah,
I'm
so-
removing them one by one.
okay.
Yeah.
Maybe these people have, walked away or stepped away from their computer. Okay. Remove, okay.
I've been helping you, Carolyn.
Oh,
I was also removing people too.
Okay,
They're down to
wait,
8
and
participants.
don't, you see Marissa is attendee. Yeah, well, you attendee. I think maybe somebody joined as you, so I'm gonna remove them too.
Okay.